Welcome once again to Live from My Office. Thank you for listening. Thank you for being here. I am not Steve Cochran, which might be the least dramatic thing I've ever said. My name is Ross Cochran. I am the producer of this program. And yeah, Steve is my dad if you are a brand new listener. But my dad is out getting a new knee. He told me to tell all of you he got it from the Knee Hut, because that's the kind of humor you can expect from a guy recovering from surgery. But on that subject, we actually wanted to bring you a conversation that we had way back in November. Dr. Charles Lupo is the surgeon who is performing the knee surgery for my father, and we talked to him back when the knee surgery was scheduled until COVID got in the way, so that Dr. Lupo could explain the procedure, so my dad could talk about why he finally decided that now was the right time. And so hopefully that if you or someone you know is considering this, it becomes a little bit more clear what having a knee surgery is really like. So enjoy this educational episode of Live from My Office featuring my dad and Dr. Charles Lupo right after the break. Thanks for listening.
If you were a family member interested in securing a reverse mortgage loan, listen to this invaluable information from Team Hochberg that I have right here on this paper in front of me. Your trusted local lender, that's Team Hochberg. Experienced homeowners, at least 62 years old, secured 44,666 reverse mortgages for them in 2020, totaling a record $10.6 billion. That's the Team Hochberg year. 2020 was bad for all of us, but he made it a little better for most of us. As a matter of fact, anybody that called Team Hochberg. These financially astute homeowners took advantage of the many benefits of reverse mortgage loans, including increasing monthly cash flow by deferring mortgage payments, the proceeds from reverse mortgage loans tax-free, extending the life of retirement funds, making home modifications to make it safer and easier to live independently, to afford in-home medical and housekeeping pros to assist with tasks around the home that become more challenging as you get older, and to enjoy your golden years without the fear of running out of money. If you'd like more information about reverse mortgage loans from local reverse mortgage loan experts, do what we do. We call Team Hochberg, 855-56-DAVID or 56david.com, and tune into Home Sweet Home Chicago, hosted by David Hochberg, Saturday mornings at 10 on WGN 720. It's Homeside Financial, an equal housing lender, NMLS number 1124061. This is Live from My Office, and, you know, all those years on the radio, and I will always do this, whatever I'm doing, talking about what I might be dealing with or going through, maybe can help you. Now, the hair loss thing, well, that ship has sailed. But it turns out I'm in the market for a new knee, and I'm happy to say that one of the finest orthopedic surgeons, one of the finest people in America, Dr. Charles Lupo. Charlie is on the phone now, so we can talk about my knee, and maybe some of this stuff will help you. Good morning, Doc.
Morning, Steve. How are you today?
I'm doing fine. Now, we've been on this journey, if you will, for a couple of years now. So, and I think people could probably relate best to where they might be on it as well, or where they might be headed. So I am 59 years old. I've got a couple of pre-existing surgical issues, the most important of which is 3 pulmonary embolisms, a propensity for blood clots, which you get with surgery. So there's some extra layers of this that come in. But let's go back to where you and I met. And the initial treatment for this was Synvisc, or this injection of what do you describe it? What is the thing you put in to cushion the knee prior to surgery?
Yeah. So usually when someone first comes in to see us, and we can make it, we're assuming we're going on the diagnosis of arthritis. I am an orthopedic surgeon who my specialty is in hip and knee replacement predominantly, which the number one reason for that across America is kind of your standard wear and tear arthritic disease, whereby the cartilage or the padding tissue that lines the end of the joint, and in your case, Steve, being your knee, you wear that cartilage out. And similar to wearing out the brake pads in your car is maybe a reasonable analogy that people can understand. And when that happens, you start to get what many people describe as bone-on-bone disease, and that's where the pain arises from. And so our first line of treatment is usually non-surgical. Not everybody who presents with arthritis, and most people who initially present with arthritis do not need to jump into a surgical fix for that. So we try a number of non-surgical things, medication, physical therapy, low-impact exercise, and then injections come as a mainstay of treatment for many people. And the injections really come in two flavors. There's your standard kind of cortisone or steroid injection, whereby you try to reduce the inflammatory component of the arthritis. And then there's these alternative injections that you're referring to that come in a number of descriptions, but mainly it's a substance called hyaluronic acid. It is a synthetic material that is made in a laboratory that is supposed to mimic the normal fluid that is made by the cartilage when present to lubricate the joint. And so some people get a couple weeks, other people can get several months worth of relief out of it. It is something to kind of try. It doesn't cure the arthritis, but we did those and have been doing some injections on you for the last 2 years. And they work for a time, and over time their efficacy can kind of wane, and then we start to talk about the other alternatives. But that's what we did for you. We tried those gel injections, many people call them. Some people even call them rooster comb or the chicken shots. You'll hear many names.
Which is funny because they're made from rooster comb, right?
Correct. Some of the building blocks of that substance that your knee makes to lubricate the joint, collagen and other proteins and sugar complexes actually are found in the comb of a rooster, the red kind of spongy tissue that the roosters have, and then they can extract some of that and make it into a lubricating tissue that is the goal is to try to help people with arthritic disease get through daily activities and have a normal functioning life to the best you can when you have arthritis.
So after the HA, the hyaluronic, that acid thing you mentioned. After that, we went to cortisone. And in both cases, what you just indicated was true. They work for a period of time, and then eventually they stop working. So does the body just get used to the substance and say, yeah, no more for me? Or why is it that they can work for a period of time and then they stop working in regards to reducing the inflammation?
Yeah, that's a good question. And I don't know if we have a definitive answer to that. I have some patients who have the same amount of arthritis on the X-ray, radiographically, but the way that arthritis affects them is substantially varied. Some patients have really bad arthritic disease, end-stage bone-on-bone arthritis, and they tolerate their symptoms reasonably well. There are other patients who have more moderate arthritis or even more severe arthritis and really have struggled in their ability to get around on a daily basis, to have a regular and normal quality of life. So even right there, it shows that, the X-rays themselves don't often dictate the amount of disability that people experience. Why in the beginning the injections work better than as time goes on, I don't have a great explanation for. I think some of it may be the body does get used to it over time. That would make sense logically, although I don't know how you prove that scientifically. I also think as time goes on, arthritic disease just becomes more progressive. You lose more cartilage, you get more of a deformity, and your ability to tolerate daily activities becomes more difficult. So I don't know if it's that the injections are becoming less efficacious or that the arthritis is progressing. It's probably a combination of both would be my best guess.
And just a primer on osteoarthritis. Pardon me. We'll edit that cough out. But the osteoarthritis, it can spread to other joints, right?
Well, I think people experience it, whether they have a genetic propensity to it, whether it is the environment or their occupation or their level of exercise, their weight. There's many factors that go into arthritis presenting itself in various joints. From our best understanding, unless you have an underlying autoimmune disorder like rheumatoid arthritis or lupus or other inflammatory disorders, then yes, in the sense of it can spread, meaning that process can occur in other joints. I would think in more of a traditional sense of spreading, you could consider it that way. When it's wear and tear arthritis, I don't think it's spreading in the way that you have it in your left knee, and now there is a process whereby that is metastasizing, so to use some cancer terminology, or translocating to another joint. I don't think it's a process moving itself to another joint. It's probably just the same mechanical process occurring in other joints because for whatever reason you are susceptible to getting arthritic disease from a number of environmental, genetic, and kind of daily life factors.
All right, well, that makes sense, and it's well put by you. So I can have osteoarthritis in one knee or both knees, and if I get it in my hands or whatever, it's because my body, my metabolism, my makeup, whatever the words would be, is more likely to have that happen. That makes sense. It's common sense, I guess.
Yeah, and we may find out. We're always finding out new things each successive year, and research is always ongoing. That maybe there is a process whereby it somehow translocates and physical, mechanisms are occurring that then do it. But as far as we know from the available evidence, we can't say we can put a direct connection from left knee to right hand, and that those two things are invariably connected. Just we can't say that at this point, but certainly in the future we may have a different discussion about that.
So as of right now, I am scheduled to have Dr. Lupo do a right knee replacement in early December. We're recording this on November 15th, well aware of the fact that could be postponed indefinitely because it's an elective surgery and there's a need for what's more important right now, and that is to be able to have beds to take care of the COVID patients. But we're going to press ahead here and at least do the setup for this as if we are going to go through with it. So is it a total knee replacement? Because, when you first hear those words, you think you're going to hack off the knee, top and bottom, and then slap them back together. What is it?
Yeah. So there are knee replacements do come in a few varieties. People will hear about a partial knee replacement, which certainly is done across the country, and a total knee replacement. Oftentimes, it's multifactorial as to who's a candidate for one versus the other. We are doing a total knee replacement on you because the entire knee joint, there's really three components or three sections to the knee, three compartments we call them, and all three compartments, the medial compartment, the lateral compartment, and then underneath the kneecap on you have arthritis throughout. And so to only do a partial knee replacement where you would put a device in to just take care of arthritis in a specific segment of an individual knee joint, you don't qualify because that would leave remaining arthritis in the other segments of the knee that would not be replaced. So there's a time and place for a partial knee replacement, but you're, Steve, are lucky enough to have disease throughout the whole knee.
Good for
me.
So
yes, we will. So you fall into that category, and so you'll get a complete knee replacement whereby we do cut, the ends of the bones off that are arthritic. We shave off that arthritic cartilage, and then we use an implant to cap the ends of the bones. That's kind of a metal implant that gets placed onto the ends of the bones and caps them. And then in the intervening surfaces, so the metal isn't contacting the metal, there is a polyethylene component that gets placed in between them, and that really recreates the cartilage surface or the shock-absorbing padding tissue in the joint. So instead of having that bone-on-bone disease that we identified on your x-rays, that you now have this device recreating the moving surfaces of the joint. At the same time, you have a bit of a deformity of your knee, which many people get with arthritis. You have a bowing deformity of your knee, and in conjunction with replacing the joint, our goal is to realign that knee so that mechanically it's kind of realigned so that you no longer have the bow in the knee that comes with arthritic disease. You have the native anatomic alignment to allow a healthy transference of your weight through that knee joint.
Yeah, and is that what goes to the situation I'm in now where I've got a little bit of the Herman Munster walk? The stiff Frankenstein, the stiff-legged walk, because the flexibility, yes. I'm not pulling a golf ball out of the hole without, some effort, and I'm not crouching down and playing catcher and softball anymore, or baseball. The flexibility just isn't there. So is that the bowing you're talking about?
Partially. So what happens when you get arthritis is not only do you wear the cartilage down, but your body creates these large bone spurs on the periphery of the joint. And those bone spurs take up space. They occupy or tent the tissues in the back of the knee that can prevent your knee from getting all the way straight. They can develop in your case, on the inner portion of the knee and can kind of contract the tissues so that those tissues aren't functioning at their normal, healthy physiologic length. And when that occurs, you can start to develop either a bow-legged deformity, which some patients get, or if you develop more arthritis on the outside of the knee, you'll see patients come into the office or even people walking down the street with a knock-knee deformity. And so Either of those need to be corrected at the time of surgery. And when you do correct that, the range of motion can often improve because you decompress that joint space and you allow these tissues to start functioning at their normal working length. You help them kind of regain their flexibility over time. That doesn't happen immediately after surgery. Those tissues need a few weeks or even several months to stretch out. And I think it underlies the point that I try to impress upon you in the office and also to patients I see regularly, is that when it comes to knee replacement and hip replacement, which I do both of, I often tell patients the pain relief and the functionality with the hip replacement tends to come along a little bit quicker. I liken it to flipping on a light switch. When you get your hip replaced, it is very akin to flipping on a light switch where you almost immediately feel a relief of pain. When it comes to knee replacement, it's more like raising a dimmer switch. It takes a few weeks, even the first 2 to 3 months, to try to get your function back, to regain your ability to walk with a normal gait, to get the strength of the supporting muscles around the knee back and in good, healthy working order, and to also get the ligaments that balance and help support the knee back at their working functional length. So it's a bit of a process. Your journey will not end once the surgery is complete. And there's a process afterwards.
Yeah, and we'll take that up in part 2 of this, which you probably don't know.
No doubt.
Probably don't know you agreed to do when we get
I did now.
closer to the surgery or just past it. All right, so part of your job, obviously, is managing patient expectations. So when somebody is at a point where they need surgery and they're ready to go, well, actually, let me back it up even further than that. What's the best way for someone to know it's time to get a knee replacement? Is it lifestyle, or is it physical, or is it both?
Yeah, that's a great question. And I think that underscores something as I've evolved in my practice and I've treated more patients and seen more people after surgery. It seems like as the surgeon, one of the best things I can do is set reasonable expectations for patients. And so this is a topic I like to speak of because I think sometimes surgeons like to project confidence in what we do, right? You want people to understand that we're going to make you better, but you also have to impart upon patients that in the end, this is a knee out of a box, right? It's metal, it's plastic. Many times it's cemented or grouted into your bone like the tiles in your bathroom are grouted together. It is not the knee that Steve Cochran had when he was a young buck at the age of 25, living life not thinking about your knee. It's a mechanical device. It has some limitations. I really tell people the goal of our surgery is to make you better than you were, certainly to limit the pain that comes along with progressive arthritis, to stop the ongoing or downward trajectory that people have. You over time, since we've met you went from playing however many rounds of golf a year to less than that. Your ability to do daily activities and to get your exercise has gone down in the several years I've known you, and that's common for most patients. So what I try to tell people is we want to be able to get you to a level where your pain is certainly much less than when we started. Functionally, you can do more things: stairs, going on long walks, hiking, biking, swimming, taking care of your grandkids, going to your family, the soccer games, and all the things that people like to do when they get into their older years and they've been dreaming about their retirement. They retire, and the next thing you know, their knee goes bad and they can't do all the things that they were hoping to do when retirement came. So I think for most daily activities, people get better with knee replacements. We don't really design knee replacements or encourage people to get back to running marathons and 5Ks. And it's a mechanical device. It really can't handle a lot of those high level activities. So I think what people need to understand about joint replacement is it's an excellent surgery. Most patients can expect at least a very good to an excellent result, but there are limitations. We have to be reasonable about what we as surgeons can provide for people, whereas the body has developed this beautiful, complex knee joint over many, many thousands of years here, and we're trying to recreate that in our 40 or 50 years understanding of knee replacement surgery. So I think managing expectations is big. To go to your other question, I think is important is how do I know? When do I know that joint replacement is right for me? And usually what I tell people is it's not so much based on your x-rays. We shouldn't have surgeons just coming into the room, looking at an x-ray and saying, well, you need your knee replaced, without actually understanding how does that knee on the x-ray affect this person on a daily basis. If it affects your quality of life, if you can't exercise, if you can't sleep, if you have difficulty doing what we call activities of daily living, getting to and from your job, going up and down stairs, taking care of your lawn and your backyard and things around the house, that's when the time for joint replacement is. It's really based off your symptoms and how much it bothers you, not so much just the fact that you have arthritic disease.
But if you leave it alone for an extended period of time, the damage does get worse, right?
It's seemingly so, yeah. And you kind of got to thread a needle a little bit with patients when it comes to knee replacement, because if you do it when the patient still has a very functional knee, whereby they don't have a lot of restrictions despite having some pain that can be limiting, those patients may not like their knee replacement, even with a little bit of pain, more so than they would like they're still having their own knee in place. When patients kind of get to the point where, so that's one set of people where you don't want to do it too early, and then you're giving them a knee that is more mechanical feeling when they haven't had symptoms for very long and they don't have a lot of restrictions in their life. The converse to that, or the other side of that coin, is that sometimes people can go a little bit too long and then they become very debilitated. They become cane or walker dependent. Their mobility has gone down. They become deconditioned because they're very sedentary. It seems like those patients, and there's some studies to support it, they may have a little harder time getting back to normal and having a real outstanding outcome. It seems like the people in the middle who are fairly debilitated by it, they are not terribly deconditioned yet. They're still able to get some exercise in. They have functional deficits, but they're teetering on the ability to really get around without thinking about their knee a lot, or planning around their knee, or paying for activities down the road. If they try to go to their grandson's soccer game and they got to walk 3 fields and back to the parking lot, and then 3 days later they're still hurting, that person is starting to get in the sweet spot where functionally they're able to still do a lot of daily activities, but if they're starting to become restricted, it seems like those are the people in the sweet spot who do best with replacement surgery.
And obviously this is mostly people my age and older, but you do see this in younger folks as well.
Correct. Yeah, you're at about the average age, or in that range of where people in America are getting their joints replaced. Certainly, younger patients they tend to not have run-of-the-mill arthritis. These are often, when you get patients in their 40s or 50s who need a hip or knee replacement, they've often either had some sort of congenital problem with development of the joint, or they have things like rheumatoid arthritis or other autoimmune diseases that have been brewing for many years since they were in their young adulthood, and now it's culminating in their 40s or 50s, or someone who has had past trauma, a past fracture or injury to the, we see a lot of injuries to the ACL and the anterior cruciate ligament or the meniscus tissue in the joint, and that could put people at a higher risk of needing a joint replacement surgery at an earlier age. But you're kind of around that average age of where most people in the U.S. are getting their joints replaced. Late 50s, early 60s.
Right. So I'm 59. So we'll talk about how important the post-surgery therapy is, the physical therapy, and how you got to do it to get the full benefit of the surgery and to get back to life faster. But realistically, when these surgeries go well, how long do these joints last?
That's a good question. With modern implants, we tend to think they're going to be lasting longer than the implants we had in the late 90s and early 2000s. The main data that you could probably quote would be that most knee replacements, if you did 100 knee replacements today, in 20 to 25 years, probably about 75 to 80% of those patients still have a functioning joint in place and have not had any further surgery. Certainly, I tell all my patients, I'm a human being putting metal and plastic parts in you, right? As much as we do a lot of these, and we do extra years of training, specifically in joint replacement and reconstruction of the joint, I'm putting a mechanical device in you. And mechanical devices, like anything else in life, can fail. It's not common, It's not a reason to not do it, and we're always refining our technique. But I think if you had to give the average person on the street an understanding of their likelihood of success, we usually say about 75 to 80% of people at 20 to 25 years still have a functioning knee replacement in. As newer implants stay on the market longer, we will have longer term data, but the more modern implants that we think will last longer just haven't been on the market long enough to follow these patients to say whether that's going to come to fruition. But I think most people can expect a reasonable result in the long term, but there are patients who do require other procedures. That's just being transparent about it. There's no guarantees in life like anything else. I think the important thing is, finding a surgeon who's well versed in revision surgery and can take care of any mechanical issues that may occur, and be able to have the tools in their toolbox to handle issues as they come up, which is rare but possible.
Yeah, and I guess for this first part, we'll just leave it at this, that the responsibility of the patient post-surgery is to do the physical therapy and all that, but also to maintain a healthy weight, to get exercise, and to know that just because you got an artificial knee doesn't mean you could go back to bad habits that maybe helped increase your possibility that you needed the surgery in the first place.
Absolutely. Very, very well said. For all the times we've been together, you've been listening to what I'm telling you. It sounds
right.
Like, because you're
giving
me my talking points. Exactly. But it is true. We know, and it's pretty well known in orthopedic surgery, that healthier, more fit patients with a healthier weight, they just tend to have less complications. There are many factors that could lead to a bad outcome, and certainly within the surgeon's hands, there are many that are outside all of our control, but the patient does have some control. I like to tell my patients, joint replacement does not happen to you. It happens because of you. It is not a passive process. So maintaining a healthy weight, keeping your medical issues well looked after and under control, diabetes, not smoking, healthy diet, good exercise, good sleep, all of these things play into the recovery. And if you get your knee replaced and think, I had it replaced and now all these doors will be unlocked for me. Many times they are, but it's with the understanding that you put the work in. It has to happen because of you, not just passively to you. So the journey for the patient really starts getting through the surgery. And then as we talked about, we'll kind of document this as we go, but it is some onus is on the patient to try to be healthy, certainly leading up to surgery, and then that has to continue into the after-surgical time frame as well.
Yeah, well put. All right. I think we've done a decent job of setting this up. So next time we talk, we will do part 2, and that'll be what happens post-surgery, maybe a little bit of in-surgery. I'm sure you sing to me while I'm out. And then where it goes from there. But I hope that helps people at least a little bit to think about where they are, what they might do, and to consider having a better life than they have now. Because as you know, Doc, you can get used to the pain. You can get used to this. Well, this is what they feel like. And then, you go years that way, and then it's maybe not fixable.
Yeah, no, I hear that a lot. People come in afterwards. Usually for the first few weeks after surgery, people don't like me very much. They say, "Look what you did to me," and that's why I try to set the stage very early on beforehand. I use the dimmer. It's like a dimmer switch, raising up slowly. You're not going to feel immediately better, and ultimately, I'm not giving you a haircut. I'm replacing your joint here, and so we got to have a little bit of mental fortitude to understand that this is what we're getting ourselves into. But I think in the end, most people, if they have a reasonable expectation about what we can do for you, if you try to get yourself in the best place to have surgery, and maybe, try to stay a little bit of fit and in some reasonable conditioning ahead of time, you're setting yourself up for at least a good chance at an outcome that you'll be happy with.
Dr. Charles Lupo, one of the finest orthopedists on the planet. I mean, I don't go to any hack. I go to the best.
I don't know what ranking system you're going off there, but I'll take what I can get.
And all part of the Northwestern Medicine System. Specifically, what is the name of the practice?
I'm out in the west region of Northwestern. There's a couple. Northwestern is a larger grouping of several kind of regional areas. We're out in the West region. I'm primarily at Central DuPage Hospital is in Winfield is where we operate. We're called the, regional medical group for Northwestern medicine. It's kind of we cover the West region, Northwest areas of the city, Wheaton, Glen Ellen,
Sure.
Winfield, Warrenville, all these areas out that way. So.
All right, Doc. Well, I appreciate your time very much, and we'll do it again. Thanks for being on Live from my office.
All right, Steve, thanks for having me, and look forward to getting you taken care of here in the future, buddy.
30 years plus on the airwaves, you have turned your dial to me. Now you're tuned into my podcast. It's Live from my office, Steve. From Ithaca, New York, to Carolina South, W. Cochran Steve. From Minneapolis and then Chicago twice, top-rated shows achieved. Sit back, relax, and now listen to my show. When or wherever you are, 'cause you're on the go. A-list celebs with some laughs and great info. Live from my office, the Steve Cochran Podcast Show. Yeah, yeah, yeah. No better place to be. Yeah, yeah, yeah. Subscribe and like for free. Yeah, yeah, yeah. Live from my office, Steve. So glad you're with me. It's Live from my office, Steve.
Thank you for listening to Live from My Office, a service of Monkey Run Productions. All rights reserved. The podcast is hosted by Steve Cochran, and it's mixed, edited, and produced by me, Ross Cochran. Support the show by subscribing wherever you're listening and by telling your friends about it. Follow Steve on all social media channels, including Facebook, Instagram, Twitter, and LinkedIn. And make sure you check out this episode's show notes for relevant information discussed during the conversations. You can also email the show directly at thecochranshow@gmail.com with any questions or comments. And that's the best place to tell us about your favorite nonprofit so we can make sure we mention them on the next episode. Steve is available for corporate speaking gigs. He would love to MC your event. And occasionally, he's funny. Thank you for listening. Head to cochranshow.com for more.